Welcome to this session. I'm Professor Adeyemi Babalola, the current head of Department of Obstetrics, Gynecology and Perinatology, Faculty of Clinical Sciences, Obafemi Awolowo University, Osun State. Today, we are going to study maternal mortality and perinatal mortality and morbidity. The objectives of our study of these two topics are to define maternal mortality and morbidity, perinatal mortality and morbidity, then familiarize ourselves with basic global terms in these parameters, know the causes of maternal mortality and perinatal mortality, understand the common morbidities associated with them, and how to take preventive measures. First, we start with maternal mortality. Maternal mortality is defined as death of a woman while pregnant or within 42 days of termination of pregnancy, irrespective of duration and site. It is a direct maternal death when it results from obstetric complication, and we have indirect maternal death when the death is due to pre-existing problem aggravated by pregnancy state. We also have some deaths that are not statistically part of maternal mortality. We call them incidental or accidental death. That's this death in a woman while pregnant, like road traffic accidents. We use two parameters to measure maternal mortality. One is maternal mortality ratio, and the other is maternal mortality rate. Maternal mortality ratio is the number of maternal deaths in a given period per 100,000 live births. And while rate is the number of maternal deaths by 1,000 women of reproductive age in a given period of time. For the sake of global comparison, we shall be making use of maternal mortality ratio. There's another concept we call adult lifetime risk of maternal death. That's the risk of a 15-year-old woman of dying from complications of pregnancy. It has a formula. If you know that is the population of women between the age of 15 to 50 years, and you know the life expectancy at the age of 15 years, it's easy to calculate. Maternal mortality problem. Measurements of maternal mortality are likely estimates, as accurate and reliable statistics are absent, especially in developing countries. In 2017, 810 women died daily from preventable cause. And out of these 250,000 per annum, 94%, that's 277,000, occur in developing countries where 75% of world women live. So now maternal mortality is a public health issue, as women are dying in the process of an essential physiological function necessary for perpetuating human race. 90% of deaths in women actually, globally, is pregnancy related. Things have improved over the years, in the last 25 years. It used to be up to 20% globally. It was about 26.3% about 20 years ago, but now it's 99.2%. The lifetime risk of maternal death is 1 in 190 globally. In developing countries, 1 in 3,700. In sub-Saharan Africa, the lifetime risk of maternal death is 1 in 37, a poor figure. Australia and New Zealand have one of the highest figures. That is, the risk of a woman dying from pregnancy-related problem is 1 in 7,800. Sub-Saharan Africa has 66%, 196,000 of global maternal death, while Asia has 20%, which amounts to 58,000. For now, Nigeria has the highest maternal death in the world, with 67,000 per annum. That amounts to 23% of global estimate. When we talk in terms of the ratio, the world average is 211 per 100,000 deaths. In Europe and America, it's 12 per 100,000 deaths. In Sub-Saharan Africa, it's 542 deaths per 100,000 live births. Well, from North Africa, things seem to be better with 112 per 100,000 live births. Nigeria has one of the highest figures in the world. It's very high with maternal mortality ratio of 811 per 100,000 live births. South Africa has it's much better, but a lot can still be done. It has 119 per 100,000 deaths. There has been global decline in the last 20 years in maternal death, but it has been slow, that is less than 5,000 per annum, or stalled in Nigeria. There is a drop of about 38% worldwide in the last 20 years, but this has not reflected in the figures in Nigeria. Sustainable Development Goal, Target 3.1, aim to end preventable death by 2020 such that maternal mortality ratio will be less than 70 by 100 live births. I wonder how we will be able to achieve this. We need to work a lot. There are serious implications of maternal mortality and morbidity, and that is why it is drawing our attention, and that's why it's a public health issue. There is a huge loss of productive workforce to the nation. Women contribute a lot to agricultural growth, in planting, in harvesting, in sieving, and in strategic distribution of food and food security. They move food from one place to the other, and they also get it from market even to prepare for individual families. Apart from these losses, into this in this aspect in which women contribute, the infant and childhood mortality in children who have lost their mother is relatively higher, almost 5 times higher than the one whose mother survived. There is increased tendency of vicious circle of poverty in the next generation because the presence of mother makes a lot in the socio-economic achievement of the child, especially in this polygamous setup. The causes of maternal death, as stated, I would like to quote one man, Mahmoud Fatala, a contemporary prominent Egyptian obstetrician, who says the road to maternal death is long and tortuous. So there are immediate and remote causes. The immediate cause may be direct or indirect. So understanding of the remote causes is important for their prevention. So we will group them into medical causes, which most of us are familiar with, health-related causes, reproductive factors, and socio-economic factors. Medical causes are antepartum hemorrhage, postpartum hemorrhage, we all group them as obstetric hemorrhage, obstetric labor with or without uterine rupture, severe preeclampsia or eclampsia, peripartum infection and puerperal sepsis, anemia, and unsafe abortion. Health-related factors include deficient treatment of medical complications, lack of essential supply and trained personnel in where they are sourcing services, lack of access to maternity services in some area, lack of perinatal care, and delay in delivering the required service to patients due to poor organization, personnel shortage, or misdistribution of resources. There are other reproductive factors. Maternal age, teenagers and women above 35 have higher risk of maternal death. Young adolescents in the age of 10 to 14 years have the highest risk of maternal mortality than women in other groups. And this are likely to be common where childhood marriage is important. Parity of 5 and above, unwanted pregnancy and no use of contraceptions are also the reproductive factor. And there's a hint we use to teach, we call them 4T. That is when pregnancy comes too soon, too late, too much, too frequent. So we use that mnemonics to remember reproductive factors that may contribute to maternal death. Socio-economic factor, and in actual fact, these are the fundamental problems leading to order that buttress, try to aggravate or immediate remote determinant of some of these other causes. Poverty, generalized poverty, poor formal education, which lead to poor health-seeking behavior, poor nutrition lead to poor development of the pelvic structure, poor utilization of available health services, which also can also be linked to poor formal education and poverty, because in many parts of developing world, health services are sought out of pocket. They are not free. Low status of women also affect them, lead to poor health decision making or health initiative. They have to wait for the husband. They cannot take action on their own, and they are not economically empowered because they were low stature. There are also poor transportation and communication systems which reduce access to health services and cause delay in reaching hospitals or the nearest health facilities when there is need for emergency or certain intervention. Generally, we have poor funding of health, with most of the developing world not allocating appropriately. They are expected to allocate 10 to 15% of their GDP to health services. So poor funding, like in this country, hardly has it gone above 5% in the last 20 years. Lack of priority on the issue of maternal mortality by government. Because when there is a will, there is a way. Most of this problem can be solved with when government is sensitive to the problem. I want to categorize delay related to maternal mortality. Delay in deciding, first grade or first category, delay in deciding to seek for appropriate medical assistance for obstetric emergency. Then there could be delay in reaching adequate health facilities, and there could be delay in receiving adequate care when a health facility is reached. Most often, these three models of delay come into play in many cases of maternal mortality that we have reviewed. Then morbidity. Morbidity is defined as any acute or chronic physical or mental illness directly related to pregnancy and delivery. That's maternal morbidity. About 15 to 20 million maternal morbidities exist worldwide, and about 35 morbidities to one maternal death. So which means if there is one maternal death, there are about 35 people possibly in that environment who have had challenges that could have led to maternal death. Some of these morbidities are the need for massive blood transfusion, myocardial infarction, kidney failure, aneurysm, complication of pre-existing medical problem, and depression. They are all morbidity. Afterwards, when they recover, they also have to cope with chronic morbidity like vasovaginal fistula, rectovaginal fistula, uterovaginal prolapse, infertility, genital incontinence, dyspareunia, chronic pelvic pain, and chronic PID. There is also a concept called near miss. According to WHO, it is a woman who nearly died but survived a complication that occurred during pregnancy, delivery, or within 42 days of termination of pregnancy. So this is sort of a severe morbidity. Near miss is also an indices of where they have tackled the problem of maternal mortality to a large extent. It's also an indices of trying to measure the level of quality of health services. Cardiovascular dysfunction, they can present with vascular dysfunction, respiratory dysfunction, renal dysfunction, coagulation disorder, hepatic dysfunction, neurological problem, uterine dysfunction leading to hysterectomy. Now, prevention of maternal death. There are no easy or short course to preventing maternal death. Increased awareness of the problem of maternal death is one of the major keys, especially at the government quarters. Poverty elevation and closing the gap between the rich and the poor through good governance. Political reforms by strong commitment from the government to reduce maternal mortality. Improve health facilities through proper funding of primary, secondary, and tertiary services to provide essential services. There is need to create advocacy, so create awareness and encourage political will to tackle problems of maternal mortality. Universal health coverage using primary health care as a pivot has been known to reduce maternal mortality a lot. This has been proven by the situation in Cuba and Israel and Russia. And skilled birth attendants at all deliveries. Skilled birth attendants. It was found out that the developing countries who have been successful in reducing their maternal mortality ratio in the last 20 years were the ones who have improved coverage of skilled birth attendants at all deliveries. The proper referral system through transport and communication services. Universal, basic, and compulsory education of good quality without gender discrimination. Campaign against harmful cultural practices like female circumcision, religious doctrines that prevent people from seeking help, staying in religious houses instead of coming to hospital, and endemic corruption in the society. They all contribute to maternal mortality. And to capital, operational research into maternal death to identify which of these factors responsible for maternal death is most significant in any community. For instance, we know that in a country like Nigeria, in area, the major causes of maternal death start from eclampsia to postpartum hemorrhage. In some area is purpura sepsis. In some area is postpartum hemorrhage. So operational research we bring out so that a more tailor-made approach can be made in tackling societal problem. In summary, maternal death is the worst tragedy that can happen to a couple. It has serious implications in the socio-economic development of the family and the nation at large. Maternal deaths are largely preventable within the resources available to most parts of the world, provided there is a political commitment to tackle the problem. Thank you for listening.